All right, we're going to do a podcast here on how to choose a breath type and a mode for mechanical ventilation. This has been probably the topic I've received the most questions on, so hopefully you find this useful and beneficial. So let's discuss a basic overview. And before I get started, I know everyone was really excited about PRVC. And it is a very cool mode of ventilation. It's a cool breath type. It's a cool way to treat critically ill, very sick patients. But before we even discuss PRVC, we need to thoroughly understand volume and pressure control ventilation, how they work, when we would use them, how to augment them, how to troubleshoot them, before we even talk about PRVC. So from this point, we're not going to discuss PRVC as a mode of ventilation until we get closer to the end of this program. I want us to master volume ventilation and I want us to master pressure ventilation before we talk about and move on to PRVC. So we're going to establish our own standards of care. For adult patients, we will volume ventilate in SIMV with pressure support. We might switch to pressure control ventilation, SIMV with pressure support, if our patient is failing volume-based ventilation despite troubleshooting mechanisms. Pediatric patients, we will ventilate in pressure SIMV with pressure support. They will likely need a shortened I time, and they probably will use a little bit less PEEP to start off with. Not always, but they might. They'll probably have a little bit quicker respiratory rate as well, depending on the patient's size. Infant patients, we will ventilate in pressure SIMV with pressure support. They will definitely have a shorter I time. They will definitely use a little less PEEP, and they will definitely have an increased respiratory rate when we begin to ventilate them. Adult patients, volume SIMV with pressure support. Peds, pressure SIMV with pressure support. Infants, pressure SIMV with pressure support. These are good standards of care for critical care transport providers. We will discuss PRVC at a later time. So let's look at each of them now. Adults, we're going to volume ventilate. We're going to volume ventilate an SIMV with pressure support of 10 centimeters of water at least. We will always use pressure support in the emergent or critical care transport setting for our volume ventilated patients in SIMV. We're not looking to wean patients off. We're not looking to make them work harder. We want them to be nice and comfortable, let them relax, and if they're taking spontaneous breaths, SIMV is going to be their friend. SIMV, remember, is SIMV is SIMV. It doesn't matter if you're using volume ventilation or pressure ventilation. SIMV just means that if they take a spontaneous breath, they get as much flow as they want, they can have the breath as quick as they want, and they take as much air in as they want, then they get to end their own breath. They're in control of how they get the air on their spontaneous breaths. Their controlled breaths, it's just like assist control or control mode of ventilation. They get what they get whatever you set on the machine. SIMV is just a much more kinder and gentler mode of ventilation for critically ill patients that are spontaneously breathing. We don't want to paralyze our patients long term. We want them good and sedated and pain managed. And if they're breathing a little bit over the vent, that's fine. We just want to augment it and keep them safe. And that's why SIMV is our friend with pressure supported breaths, whether it's volume or pressure. But so for adults, volume, SIMV with pressure support of 10. This is going to work for the grand majority of your adult patients. You might need to pressure control ventilate an adult, but that's only after you've troubleshot all of the things you can with volume-based ventilation and it's just not working. Then you might switch to pressure SIMV with pressure support for your adult patients and titrate those airway pressures up to create a good volume. But in volume SIMV, we're going to set a good tidal volume starting about 500 cc's. Remember, we're looking at about 6 to 8 cc's of ideal body weight, so that might change a little bit, but 500 is a good safe jumping off point. Respiratory rate of about 12 is good. PEEP of 6 centimeters of water is a good place to start. And an inspiratory time of 1 second. That's a good place to start, allows for good inhalation phase and a good long exhalation phase for the majority of these patients. That's wonderful. FiO2 is patient dependent. You're going to have to titrate that dependent on your patient's need, and we're going to always offer at least a pressure support of 10 centimeters of water. We might go up from that. Troubleshooting pressure support and other things is discussed in a different podcast. For those of us that are using the Revell, when you turn on the Revell and you say adult intubated go, this is what you get. Notice a respiratory rate of 12, inspiratory time 1 second. That creates an IDE ratio, as you see on the screen, of 1 to 4. That's a good IDE ratio. Tidal volume of 500 with a PEEP of 6. Drop down a row and you'll notice the breath mode defaults to assist control with a breath type of volume-based ventilation. So all you have to do is take that breath mode and switch it to SIMV and lock it in. You'll notice that the Revell defaults to an oxygen of 21% FiO2, so you're going to have to titrate that up as well. Going up to 40 or 50% is a good place to start for patients that are, say, mildly hypoxic or doing all right. You might want to go up to 60, 70% pretty quick for someone who's pretty hypoxic. And when in doubt, for profound hypoxia, just go all the way up to 100% to rule that out. And you'll adjust other things. And we talk about troubleshooting hypoxia in a different podcast as well. So when we have these settings, we're going to evaluate and we're going to titrate. In volume-based ventilation, you're going to look at a peak inspiratory pressure and a P-plat. Those are going to tell you resistance in the airways and the tubing and the vent circuit. And the plateau pressure, of course, is going to tell you lung compliance. You're also going to measure an exhaled tidal volume. And when you're in SIMV, you're going to measure a spontaneous exhaled tidal volume, or SP VTE. In these modes of ventilation, you'll also monitor auto PEEP and be able to check for auto PEEP. You're going to look at your I time and adjust that as necessary, and you're going to possibly adjust your PEEP depending on the disease process. So when we're looking at these patients, we have to keep in mind and remember to monitor our patients. Think about the underlying cause and the problem that's going on. Monitor the patient status. Are they getting better? Are they getting worse? How's my end tidal? How are my vital signs? Are they turning pink? Are they turning blue? Let's not forget to look at the patient and not just stare at the ventilator. So with pediatric patients, some changes. We're going to go to pressure control ventilation. We're going to do pressure SIMV with pressure support. We're going to hit our pressure support of about 5 for these peds patients. We're going to consider a pediatric patient anybody from about 10 to 50 kilos. That's a gray area. Anything less than 10 kilos, we're going to go to infant. Above 50, and we can consider moving to adult ventilation, although we don't have to. It depends on how the patient presents and how critically ill they are. But we're going to pressure control ventilate all of our pediatric patients. We're going to throw them in SIMV so that if they have spontaneous breaths, we can augment it and make it comfortable for them. And we're going to give them a little less pressure support than our adult patients, and we're going to hit them with 5 centimeters of water, at least to start. Respiratory rate a little higher, about 15 or so, and that pressure control should default to 15. That's a typo. It should be 15 and 6 to create a calculated peak inspiratory pressure of 21 centimeters of water. Remember, on the pressure control ventilation, you set pressure control and you set PEEP, and that creates PIP. So pressure control for peds about 15, 1-5. Justin can't type, excuse me. But I'm not going to start over at this point, and PEEP of 6 to create a calculated peak inspiratory pressure of 21 centimeters of water pressure. So that'd be reported as 21/6 for your pressure ventilation. I time should come down a little bit, about 0.7 seconds. Remember, if it's a little smaller peds, that should be even a little shorter. If it's a bigger peds, the 0.7 is just fine. And FiO2, again, will be patient dependent, and that pressure support of about 5 centimeters of water is good for them. So for those of us using the Revell, when you say pediatric patient, intubated, go, this is what you get. You have a respiratory rate of 15, an I time of 0.7. Tidal volume is darkened out, so we're not working with tidal volume. Remember, we're in pressure control ventilation. A pressure control of 15 with a PEEP of 6, and it should calculate a delivered peak inspiratory pressure of 21, and it's measuring on the test lung a peak inspiratory pressure of actually 22 centimeters of water. That's what's so you have a target PIP and then an actual PIP, and that's measuring your actual PIP. Remember, this thing defaults to pressure, but it's AC, so we have to flip that to SIMV, and the second you do that, you're going to see pressure support light up, and it's at 5. FiO2, 21%, so don't forget to titrate that up as you need to. Again, we're going to evaluate and titrate, looking at the disease process. Here's the major take-home point, and in the words of Frank, major big-time take-home point. In pressure control ventilation, you have to monitor exhaled tidal volumes, or VTE. With pressure control ventilation, that machine doesn't know that if there's a kink in the tube and it hits its targeted peak inspiratory pressure, that no volume was delivered to the patient. It's going to kick off. So if you have a kink tube, if you have secretions in the airway, and that machine is hitting those high pressures before it even hits the lungs, you're going to have no volume delivered to your patient. So you have to watch exhale tidal volume extremely closely. There's also a practical standpoint to this. Look at your patient status. Watch the rise and fall of the chest. We're going to titrate that pressure control to increase the peak inspiratory pressure and monitor tidal volume. Good practical application is crank up the pressure control 2 centimeters of water pressure at a time until you see good rise and fall of the chest and you see good end tidal CO2 waveform, and it's moving in the direction that you want to. Please, please, please understand, if you're in pressure control ventilation, someone has to pay extremely close attention to the ventilator and make sure that the patient is actually getting a volume of air. We also need to understand that in these peds and infants, if they have an uncuffed tube, that exhaled tidal volume might not be super accurate, because you're going to have air that escapes around the tube, especially if it's uncuffed, right? It's going to come out the mouth. It's going to follow the path of least resistance. So you have to watch your exhaled tidal volumes, and you have to watch your patient status equal rise and fall of the chest. We are still moving the chest, and that our overall patient status is improving, or at least not getting any worse. We also need to watch that spontaneous exhale tidal volume if they're in SIMV. Auto PEEP, we may need to manipulate eye time and PEEP. Patient status, patient status, patient status. Someone has to watch the vent and the patient very closely if we're doing pressure control ventilation. You can hurt them. They can become hypoxic and hypercarbic because they're not getting a volume of air because the tubing is kinked, and the vent thinks, man, I'm just hitting my peak inspiratory pressure. Time to kick off. I'm hitting my pressure. Time to kick off. And at a certain point, you're going to get a low minute volume alarm, but that's going to take a couple breaths. So you have to watch the patient very closely. So here's where we're going to monitor. Remember, you can scroll through. You can hit that select button on the Revel and dial until you see VTE. And so this is with pressure control of 15 and a PEEP of 6, so a targeted peak inspiratory pressure of 21. And the physiology of the test lung, it's creating an exhale tidal volume of 209 milliliters per breath. And you'll see in that right-hand corner down low, there's a low minute volume of 1.0 liters. So if it's not hitting an exhale tidal volume of a liter per minute, you're going to get an alarm. It might take a few breaths to do that. Please watch these patients closely. So infant, pretty much the same thing. Pressure SIMV with pressure support, good for all infant patients. The rate, you need to go up to about 20. Pressure control is going to be 15. PEEP's a little lower. PEEP's going to be about 3. Good place to start to give us a calculated peak inspiratory pressure of about 18. Eye time, much shorter. Little babies, little lungs, so about 0.3 seconds. Real quick, short breaths, little puffs of air. FiO2 is going to be patient dependent, and a pressure support of 5 for the spontaneous breaths. For the Revel users in the room, when you say infant intubated go, this is what you get. Breath rate or respiratory rate of 20, inspiratory time of 0.3 seconds. Tidal volume, of course, is darkened out because we're pressure ventilating. Pressure control of 15 with a PEEP of 3. Remember, again, it defaults to pressure, but it's pressure AC, so we have to switch that from AC to SIMV, and your pressure support box will light up to a pressure-supported breath of 5 centimeters of water. You have a FiO2 of 21%, so you're going to have to kick that up as well. Low minute volume alarm is to half a liter per minute, because these little baby lungs are going to create smaller volumes. Same rule as your infants. It doesn't matter if it's an adult. If you are pressure control ventilating anybody, you have to watch exhale tidal volumes. Little difference is, if it's an adult, you're going to have a cuffed tube, so your exhale tidal volume is going to be pretty darn accurate. For peds and infants, if it's an uncuffed tube, that exhaled tidal volume is not going to be super accurate. So even more important, watch for good rise and fall of the chest, watch your end tidal CO2s, check your patient status. Same theories to evaluate and titrate for your infants as it is for your peds. Please look at these patients, watch them, keep a close eye on them. We can cause some harm here, so we have to pay close attention. I can't emphasize that enough. So when would I do an adult patient in pressure control ventilation? If they're a bad respiratory patient and they're failing volume ventilation and it's just not working, I'll switch them to pressure SIMV with a pressure support of 10, same respiratory rate. I usually start at a pressure control of 15 with a PEEP of 6 for a calculated peak inspiratory pressure of about 20, and then I'll go up 2 at a time until I hit about 30 as needed and see what I get. If I get to that point and we're still not working, then I'm going to have to evaluate how to oxygenate and ventilate this patient. Remember, in pressure control, a peak inspiratory pressure and a plateau pressure are basically the same thing. You can't measure a P-plat in pressure control because when you pressure control ventilate somebody, and your I time and your pressure work a little different than volume. In volume, you deliver a set volume over a set I time, so it'll go from 0 to 500, say, in 1 second. In pressure control, the ventilator achieves the pressure of 21 centimeters of water, and then it holds that breath for 1 second. So in these real bad respiratory patients who are failing volume ventilation, a lot of times by just simply switching the mode to pressure control, pressure SIMV, just holding that breath in kind of for a second on each mandatory breath will really help them overall, and then keep their lungs safe so you don't cause barotrauma. And then their spontaneous breaths, it's still SIMV, so they get what they want. They get their pressure support, they get the air as fast as they want or as slow as they want, and they get to end their breaths. So pressure control ventilation for adults is good if they're failing volume SIMV with pressure support and you've tried everything you can think of under the sun to make them better, and it's just not working, so you're going to switch them over to pressure and see if that works. Good troubleshooting mechanism. So as I said, PRVC is it's a good tool. It's new, it's cool. It's not commonly used in emergency rooms, mostly in ICUs, and in our area, it's only the 3 big hospitals in their ICUs. It's really good for adult patients with ARDS, and we will discuss that at a later point in time. For right now, I want you to focus on mastering volume-based ventilation for adults, specifically SIMV with pressure support. Learn how to use it, learn how to augment your patients, learn how to not have to paralyze them and just sedate them and pain manage them very well. And pressure ventilation for little humans, pressure SIMV with pressure support. Again, we don't want to long-term paralyze them unless we have to. Good pain management and good sedation for all these patients. I hope you have enjoyed this podcast, and you know how to get a hold of me if you have any questions.